preoxygenation, not the same thing as denitrogenation. And we need to do both. You know this inherently, because think about the last time you had to do RSI on a patient that was satting 99% on room air. Did you not bother to give them any oxygen during the preparation phase? Of course you did. And you did that because you understand that even if the patient is already inherently preoxygenated, just based on their own good physiology and lack of shunt, that there's more that you can do by giving them supplemental oxygen to denitrogenate them. If you think about it like this, how much oxygen is in your lungs right now, sitting here listening to me? You're breathing room air, you got about 450 mils of oxygen in your lungs. But if you put yourself on 100% FiO2 and just breathe that tidal volume for 3 minutes, you're going to jack that up to 3,000 mils of oxygen in your lungs, and you're also going to increase your reservoir of oxygen dissolved in your bloodstream as well. So our goal is not only preoxygenation, but actually denitrogenation as well. So when we're working on maximally oxygenating a patient to do RSI, we need two sources of oxygen. If I've got a sick patient that I know is going to be rolling into my trauma bay in a couple of minutes, my preparation phase of the things that I'm gathering that may not already be immediately ready to go is the ultrasound machine, the EZ-IO, two sources of oxygen, and waveform capnography. And two sources of oxygen is something that we should, whether we're in the critical care transport medicine setting, at an outside hospital, or in our own emergency department setting, we should always have. There's no reason not to. So source number one is going to be for nasal cannula that you're going to ultimately use for apneic oxygenation. And that cannula might as well be a cannula that's capable of doing capnography for you during the whole process. And then source number two is going to be for either a non-rebreather or for your bag valve mask. And you may have to switch back and forth between the non-rebreather and the bag depending on how things are going. So if we attempt preoxygenation with a non-rebreather, and we've already got a nasal cannula on underneath that as well, and we're using that non-rebreather at the highest FiO2 we can generate, which is with the ball on the regulator bouncing off the top, and we have maximally positioned the patient, and the patient is still not oxygenating into the upper 90s, then we're going to have to do positive pressure ventilation. Hinckley, you say, I thought the whole tenet of RSI was to avoid positive pressure ventilation because these patients all have bellies that are full of beer and spaghetti. And you're right, generally that is true. However, there are two indications for positive pressure ventilation during RSI. And if you are not starting from a pulse ox in the upper 90s, that is one of those indications because, again, you've got to give yourself as much time as possible. So one way that you may choose to do positive pressure ventilation is going to be with your ventilator using non-invasive positive pressure ventilation. Now, in the case that we have presented here, this is unlikely to happen. We're probably not going to bring the vent with us out of the helicopter, and so this is not going to be a particularly attractive option in this case. But in lots of cases, especially in hospital, non-invasive positive pressure ventilation is an attractive option because it's more of a guarantee that you are going to avoid insufflating the stomach than if you were bagging. But bagging is the other option. Now, most bags have a manometer, such as this right here. And we have to train ourselves that if we are doing bag mask ventilation for a patient who is not intubated, to actually watch that manometer religiously. We've got a green zone, a yellow zone, and a red zone, and we need to keep things in the green zone. If you are going over 30 centimeters of water, then you are by definition overcoming the esophageal sphincter and insufflating the stomach. So we've got to keep that number below 30. Now, if we are bagging a patient and we are not getting their pulse ox up into the upper 90s, and we go ahead and do RSI anyway, then we have done the patient a disservice, because what we haven't provided them is any PEEP. And there's no reason not to provide PEEP to a patient that we're bagging, because we have this wonderful device, the PEEP valve. So if you're bagging a patient and they're still hypoxic, the next thing that you've got to knee-jerk react to is you need your PEEP valve. You need to know exactly where your PEEP valve is at all times so that you can access it quickly in every setting that you work in. The PEEP valve is a godsend, and you will be able to oxygenate virtually anybody into the mid to upper 90s with good bagging technique, using plastic in every orifice, using two-person technique with bagging, and using a PEEP valve. The other thing that you can do with a bag mask is you can actually do CPAP without actually squeezing the bag, but you've got to be careful, because if you are doing this without a nasal cannula, then if you are just holding the mask over the patient's face and you are not squeezing the bag, they are getting no flow of any oxygen, and you are essentially smothering them. So if you do this with a PEEP valve and a nasal cannula set to 15 liters per minute underneath the mask, then you are essentially doing CPAP at whatever level that you've got that PEEP valve set at. So if you got that PEEP valve dialed up to 10, then you're doing CPAP at 10. But you've got to remember that if you're doing this without a nasal cannula and you're not squeezing the bag, you're smothering the patient. They're getting no flow of oxygen. So we've already talked about positioning during preoxygenation. You want 20 degrees of head of bed elevation. Yes, you can do this even if the patient's on a backboard, and you should. And doing this gains you 60 to 100 seconds of hypoxia-free time during laryngoscopy, and it also improves your visualization during your laryngoscopy. And it's got the side benefit of decreasing ICP if that's an issue for the patient. So elevate the head of the bed of that stretcher, whether the patient's a medical patient or a trauma patient. The other thing is, if the patient is a medical patient whose C-spine is not immobilized, then we might as well go ahead and position them for optimal laryngoscopy as well, which involves ear hole to the sternal notch and the plane of the face parallel to the ceiling. And this is probably going to require, especially for obese patients, some ramping as well. So if we're optimally positioning for oxygenation, we might as well go ahead and optimally position for laryngoscopy as well. The second part, though, you're not going to be able to do if the patient's a trauma patient who's boarded and collared. If you're not yet familiar with Dr. Levitan's concept of APOX or apneic oxygenation, which he made famous in an editorial that he called No DSAT, which stands for nasal oxygenation during effort securing a tube, then please crawl out of the hole that you've been in for the past couple of years and join the rest of us, because apneic oxygenation is such a brilliant concept. It comes from the world of anesthesia, which apparently they tried to keep secret from us, but we were able to stumble upon it thanks to Dr. Levitan. And I'm still kicking myself that I didn't think of this. The concept is that even when a patient is apneic, because you have pushed your paralytic during your RSI, the patient still is going to entrain whatever gas is in their nasopharynx down into their lungs, because even during apnea, they still maintain a little bit of negative intrathoracic pressure. So, while you are doing laryngoscopy, the patient needs a nasal cannula on, and it needs to be running fast, 15 liters per minute. The patient's not going to care about the burning in their nose from that high flow rate because you have induced them during RSI. And this can buy you 100 seconds of hypoxia-free time during laryngoscopy. And who doesn't want an additional 100 seconds of hypoxia-free time during laryngoscopy to make the whole situation just a little bit more relaxed? I'll take that every time. This is something that we need to be doing with every RSI that we do. No matter how stable the patient's physiology seems, if we're not doing it, then I think we're just being excessively proud as airway managers. So there is a little bit of research out there that suggests that patients desat faster if you paralyze them with sucks than if you paralyze them with rock. The thought is that the actual fasciculations caused by the succinylcholine, which of course does not occur with the rocuronium, actually consume some oxygen and may make the patient desat significantly faster. The literature is still fairly limited on this at this point. And sucks does maintain a couple of benefits over rock. One is that you can start your laryngoscopy efforts 15 seconds sooner. You start at 45 seconds with sucks and 60 seconds with rock. And the second benefit is that you do, on average, get a little bit better laryngoscopic view with sucks than you do with rock. So this is a tough risk-benefit ratio to weigh, and I will leave that up to you and your individual decision making. RSA, rapid sequence airway. So this is Darren Brody's concept. And the concept is that when you are doing rapid sequence, that you push your induction agent, you push your paralytic, and then you go ahead without trying laryngoscopy, and you slip in an extra glottic device. So the plan may be etomidate sucks king, the plan may be ketamine rock LMA, but the point is that you are essentially guaranteed to succeed because the difficulty of laryngoscopy is taken out of the equation because you're not going to try laryngoscopy. So this is a concept that I think has great potential, and it's something to consider, particularly in cases where a patient is difficult to oxygenate. But I personally have a hard time pushing an induction agent and a paralytic and not giving laryngoscopy at least one shot, because so often that one shot is going to succeed, and then I'm going to be guaranteed to have a definitive airway, meaning a cuff blown up below the cords. But I really appreciate Dr. Brody's creativity in coming up with this concept, which I do think can be beneficial in some settings. Okay, so what if our patient in this case was combative and was actively resisting all of our efforts to pre-oxygenate him? He's not, as I presented the case, but if he had been, if he had tried to push away the non-rebreather or the bag mask every time you tried to place it over his face, and he was strong as an ox and he just was not letting you pre-oxygenate him. And so his SATs are still in the 70s, but he still needs his airway managed before you're going to transport him. What are you going to do at this point? Well, Dr. Walls and Dr. Murphy and the difficult airway people suggest that at that point, excuse me, you are in a forced to act scenario, which basically means you kind of cross your fingers, you go ahead and do RSI starting from SATs in the 70s because you had no choice, and you hope for the best. Dr. Weingart has come up with another option here called DSI, delayed sequence intubation. And I gotta side with him on this one. I think that it is a safer option. It is an option that does not yet have much in the way of published efficacy data, which is the only thing I think holding it back, but the concept is one that is beautiful and that I have seen work very well many times myself in my own practice. So what is DSI? Again, DSI is only something to think about if the patient is actively resisting your efforts to pre-oxygenate them. If the patient's just laying there and letting you do whatever you want to do to pre-oxygenate them, then there's no reason to think about DSI. But what DSI is it is procedural sedation, where the procedure that needs to be done is pre-oxygenation. And DSI is something that essentially should specifically and only be done with ketamine. The only other option might be Precedex, because Precedex, like ketamine, allows you to maintain respiratory drive and maintain airway reflexes, but Precedex is still fairly limited in its availability, and it does not have the hemodynamic stability of ketamine. So, at least for our setting with air care, this is something that we're only going to be doing with ketamine. So, you've got the patient who is actively resisting your efforts to pre-oxygenate them. You give them a slug of ketamine. That dose may be 1 mg per kg, 1.5, or 2. Personally, I'm sticking with 1.5. And the patient will, at that point, allow you to do whatever it is you want and need to do to preoxygenate them. Once they are adequately preoxygenated, you then go ahead and administer your paralytic, which is probably going to be about 3 minutes following the ketamine, and you proceed as follows. Obviously, the ketamine is still going to be in effect 3 minutes later because its duration of action is in the 15 to 20 minute range, so you don't have to re-induce them. And it seems to me to be a much safer option than the forced to act scenario. So back to our patient. We position him optimally. We put 2 nasal trumpets in him. We crank that non-rebreather all the way up so that the regulator ball is bouncing off the top, and his sats only come up to about 88. And so rather than going ahead and proceeding with RSI at that point, we're not satisfied at 88. We can't be satisfied at 88 without trying some positive pressure and some PEEP. So we don't have our ventilator with us, so that's back in the aircraft, but we do have a bag mask, and so we go ahead and we place the patient on a nasal cannula. We crank that up to 15 liters per minute. We put our PEEP valve on, and we set the PEEP valve at 10, and then we do essentially CPAP at 10 without even having to squeeze the bag, which we can do safely because the patient is getting flow because they've got that nasal cannula under the bag. And with this, over a period of about 3 minutes, we see the patient's SATs rise magically up to 96% where they plateau. And so we have taken him all the way up from 74% to 96%. We have given ourselves an incredible additional amount of time, and we've given the patient a huge additional cushion of safety. And we proceed at that point with our RSI, which goes very smoothly because we have given ourselves additional time. We have him positioned to minimize shunt, and we are doing apneic oxygenation during the RSI, giving ourselves as much time as possible. And we end up achieving a first attempt success without any hypoxia. The SAT nadir during that attempt is 92%. And once we get him intubated, the SATs climb right back up to 96%, because 96% is the best he's going to do, given the shunt that he does have from his pulmonary contusions and his aspiration. So excellent job on that one. Okay, case number 4. We're now on to the P of HOP, the pH kills, because the case that you were given is you were called out to the emergency department of a small rural hospital for a young type 1 diabetic who is clearly in DKA. And you're called to transfer her to the tertiary center medical ICU. But when you arrive, you find that the patient is obtunded. And not only that, but just as you walk up to the bedside to assess her, she starts to vomit. And you watch that as she vomits and you roll her to the side and you suction her, that she doesn't really seem to be doing anything to protect her airway. Again, you've got about a 40-minute flight back to the medical ICU with an obtunded patient who is not protecting her airway. And so you think to yourself, I don't really want to intubate this patient, but I feel like I'm boxed in. I don't feel like I have a choice. What do you think her respiratory rate is? Right, she's incredibly tachypnic. She's breathing about 38 times a minute because her brain is doing everything that it can to try to compensate for the metabolic acidosis she has. The outside emergency department has gotten a venous blood gas, which reveals a pH of 6.85 with a bicarb of less than 5 and a PCO2 of about 18. And that respiratory rate is basically what is keeping her alive. So you were really concerned, appropriately, about managing this lady's airway, and yet you feel like you got no choice because she's obtunded and she can't protect her airway. So how are you going to manage that case and avoid a serious peri-intubation morbidity or mortality? So we're talking about severe metabolic acidosis. That's what the P in HOP is, the pH kill. And point number 1 is sodium bicarb. Should you use it? Is that a solution? And my takeaway point on this is that I don't want you to kid yourself that this is any kind of a solution to dealing with this scenario. You got two solutions here, both of which you need to be doing. And solution number one is that you need to obviously be treating the underlying cause of acidosis. And solution number two is that throughout your attempt to manage this patient's airway, you must maintain as close to as possible the patient's respiratory compensation for her metabolic acidosis. And the reason you got to do that is because severe metabolic acidosis plus apnea equals a dead guy. The patient's tachypnea and increased minute ventilation is the entire compensation that is allowing them to remain alive. And apnea is going to further decrease that pH, and 6.85 is what you're starting from. You essentially have no room to go down at all before the patient's going to spiral into cardiac arrest. So, when we do RSI, there's good research that shows that in the first minute of apnea, a patient's PCO2 typically rises 8 to 16 millimeters of mercury. And then after that first minute, the rate of increase slows down to 3 millimeters of mercury per minute thereafter. And normally, for most patients, this is not a big deal at all. And it simply is clinically not significant. But if a patient is starting from a pH of 6.85 for metabolic acidosis, that's going to be a huge deal. Now, why is this basically an issue of metabolic acidosis and not respiratory acidosis? Well, the reason is that typically with respiratory acidosis, it's a problem of bronchospasm, either from a severe asthma exacerbation or a severe COPD exacerbation. And during induction and paralysis during RSI in a patient like that, you're not going to see that big rise in their PCO2 from apnea because you are essentially going to be achieving what the patient has needed all along, which is as much time as possible to exhale. And typically, once you paralyze a patient like that, they're going to give one continuous long exhalation that their respiratory distress prior to the paralysis did not allow them to have. And so you don't typically see the pH of a severe respiratory acidosis patient decrease further once you paralyze them, because you are giving them time to exhale, and you may actually be improving the pH situation of that patient. So this is an issue of metabolic acidosis. So this is the second time when we are forced during RSI to bag a patient or to provide positive pressure ventilation. Despite the underlying tenet of RSI, which is that we avoid positive pressure ventilation whenever possible, a patient who we cannot adequately oxygenate, or a patient that we must maintain respiratory compensation for severe metabolic acidosis, those are the two times when we have to do positive pressure ventilation during RSI. So there's two ways that we can do this. We can do it with a vent, or we can do it with a bag. But this is not a patient that we can tolerate 45 to 60 seconds of apnea once we push our paralytic, because they've got no room to go down on that pH. Again, we need to be using nasal cannula so that we can do apneic oxygenation, and also the nasal cannula, especially in this case, needs to be one that can do capnography, because we need to keep a very close eye on the end tidal CO2 throughout the whole process. That's going to be our gauge in the absence of continuous blood gas monitoring. So when you put that end tidal CO2 cannula on the patient before you have done RSI, is it going to be high or low? It's going to be incredibly low. A, because the patient is extremely hyperventilated because they are attempting to compensate for their metabolic acidosis, and B, because severe acidosis and shock in and of itself will lower an end tidal CO2 even in the absence of hyperventilation. So it's going to be extraordinarily low. And in this case, that's essentially good. And you want to keep a close eye on that end tidal CO2, which, let's say when you pop that cannula on, it comes up at 18. Your goal during the whole process, both during the rapid sequence intubation and following it, is to keep that end tidal right there and not let it rise, because as the end tidal rises, just imagine in your head the pH falling. So we don't want to let it rise until we can get an actual blood gas and find out where we truly are. So again, during the RSI, after we have pushed the paralytic, we're going to have to either bag the patient or we are going to have to ventilate them non-invasively. If we want to try a strategy that involves the ventilator, it's a little bit tricky, but it's very doable. And the benefit to that over the bag is that, again, in a situation like this, you are going to be amped up. Your sphincter tone is going to be high, as well as it should be, because you know that the patient's physiology is peri-dead. And in that sort of situation, no matter how calm and cool you are, it's going to be tough to keep this number below 30, which is what you need to do. So the way you do this with a ventilator is this.